I think you can listen to my voice, isn't it? Okay. So today we do discuss until this slide, isn't it? So today we are going to further, and then hopefully we can finish this topic by today. So as usual, once we finish the introduction and discussions of the basic concept of CHF, now we go into the topic of treatment. So for treatment, basically there are three types of drug normally we are going to select for this CHF. CHF refer to chronic heart failure. So the first drug we are going to discuss is cardiac glycoside. Second drug is vasodilator, and then third drug is diuretic. Okay, that especially diuretic we are going to focus on three types only because diuretic got more than three types. So for this topic, we're going to focus on three types. Because why? Because only these three types are commonly used for CHF. So for glycoside, no choice, only got one type. Cardiac glycoside only got one type. So we need to study in detail because the cardiac glycoside is quite important for chronic heart failure patients. And then the third drugs we are going to study is vasodilator. Even though last week I do discuss, I'm saying that ACI, ABR, they have vasodilation effect, but they sometimes they are not considered as vasodilator alone, because they are classified as another group which is related to vasodilations. So in this topic, sometimes we also call them vasodilator. Yes, of course, makes sense because they have vasodilation effect, but uh, that we cannot fully consider them as a vasodilator because they are not only vasodilating something, the blood vessel, they also have others activity. Okay, quite clear. The three drugs we're going to study. Okay, for vasodilator, um, there's two types. One is uh, add on vein, and then definitely we're going to reduce the venous return, and we can say that it's effect on the preload. Another type is artery dilator, which is add on artery and also may also decrease uh, blood pressure. Then this one we consider as afterload. So I make it clear. So vasodilator for vein we consider as preload vasodilator. Uh, Vasodilator add on artery we consider as afterload. Okay, they are different. Two concepts are different. You may ask me why since since uh, since the drugs the heart failure they might not able to pump effectively. So why you want to dilate the venous? Because we dilate the vein in order to decrease the renal return to reduce the load to the heart, meaning that you try to reduce the burden to the heart. So the heart, you hope the drugs, the heart can pump it effectively. So what happened about artery? Because artery is normally related to blood pressure. Once you reduce the artery by artery pressure or sometimes we call it peripheral resistance, then you are introduced environment which is allowed the blood to pump out from the heart easily. Okay, that's why two vasodilator is quite important. Some vasodilator got the effect on both artery and venous. Some only focus on one uh, blood vessel. Okay, so now quite clear, isn't it? So why we want to use a diuretic? Because diuretic, when you have a heart failure, uh, you are not able to pump sufficiently amount of blood to the kidney to excrete out the extra uh, fluid or water from the blood. So that's why the water can accumulate, may cause edema and congestions. So normally we use diuretic to helping the patient to excrete out the extra water and ion from the body. So to prevent congestions and edema. Okay, quite clear, huh? So for digoxin, digoxin is uh, ionotropic drugs, ionotropics, going to increase the contractions of the heart. The contraction force of the heart, we consider as ionotropic. So far, digoxin only available in US, only one drugs. Previously used as the first line for coronary heart failure, now considered as second line after diuretic and vasodilator. So diuretic treatments. So there's few types of diuretics here. So today we'll focus on thiazide, organic acid, and potassium sparing diuretic. Sometimes this potassium sparing diuretic also known as aldosterone antagonist because this drug we're going to compete with aldosterone. So that's why we consider as aldosterone antagonist. Yeah. So the first diuretic drug is thiazide or thiazide light diuretic. Why they call thiazide light diuretic? Because the actions is quite similar. That's why they call thiazide light diuretic. So this thiazide diuretic considered as moderate and most effective in mild and to moderate uh, patients, not suitable for severe patient with the condition must with normal renal functions. Okay, without normal renal function, I think this drug might not be effective. So thiazide will cause excretion of sodium and then may also cause loss of potassium. That's why may introduce hypokalemia. So hypokalemia is a major if side effect of all diuretic drug except aldosterone antagonist. Okay. So another thing you need to understand is or remember is thiazide diuretic add in distal tubule. Distal tubule. You highlight here distal tubule. So lobe diuretic is considered different compared to thiazide, because the location of actions is different. Thiazide is add on this add in the distal tubule while lobe diuretic is add on the handy lobe, especially ascending handy lobe. So handy lobe basically got two parts, isn't it? One is ascending, one is descending. Okay. Uh, the for the loop diuretic we add on the ascending. Okay. So loop diuretic considered as the most potent diuretic among all the four among them among the diuretics are considered the most potent. So basically used for patients who impair of renal functions and severe heart failure. So another point here is try to highlight the difference between lobe diuretic and thiazide. Thiazide cannot use for renal failure patient, but lobe diuretic may use for renal patient failure patients. So since this diuretic, lobe diuretic, okay, uh, is quite useful. So whether you want to administrate intravenous or already depend on the conditions of the patients. Okay, depend on the condition of patients. Later we're going to discuss in detail. So the example of lobe diuretic is furosemide, butanedione, torsemide. These few are the commonly used. The duration action is all average between 4 to 8 hours. So the third type we are going to discuss is aldosterone antagonist. Okay, Another thing you need to remember, this aldosterone antagonist will act on different location. Just now one thiazide will act on distal tubule, uh, loop directing will add on entry loops, and this aldosterone antagonist will add on collecting drugs. So they are different. Their reactions are different. So example of aldosterone antagonist is spironolactone, and also got others families such as epinephrine, aminoride, thiamterine. Okay, so they sometimes this group of drug can consider as potassium sparing directly because why? This drug might cause hyperkalemia. Will reserve the potassium, so that's why they consider as uh, potassium sparing diuretic. Okay, quite clear. So the difference between this and the others is they will cause retention of sodium and excretion of potassium. Okay, to prevent this retention and sodium and excretion of potassium, because retention of sodium and excretion of potassium is caused by aldosterone. Since this one is antagonist, so they're going to prevent the retentions of sodium and excretion of potassium, meaning that they're going to inhibit the excretions of potassium. So potassium is going to spare inside the cell. So that's why they consider as sparing potassium sparing diuretic. So basically, all these diuretic have similar side effect. For example, thiazide and loop diuretic may cause nausea, hypotension, hypokalemia, hyperuricemia, and hyperglycemia. So, but aldosterone antagonists may cause hyperkalemia. Of course, others side effect might also happen in uh, aldosterone antagonist, but aldosterone antagonists normally will introduce hypercalcemia compared to the others, which is may cause hypocalcemia. So bear in mind this point you need to remember. Okay, quite clear. So the mechanism of action in here we are going to discuss in another topic. So straight away we go to second treatment, second drugs. So the second drug we are going to discuss is vasodilator. Okay, why? Because vasodilator, because the drug's able to dilate the blood vessel, either is a vein or artery. That's why we call it as vasodilator. So, so that's why sometimes ACI, ARB also considered as vasodilator. But for me, I feel that artery dilator and venous dilator, such as hydralazine and nitroglycerins, are are the how to say are the vasodilators, because these two are quite important. Normally, this one will come up in uh, essay. They will ask you to 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 define arterial dilator, venous dilator, and both artery and venous dilator. So you can define according to the information from the slide. Okay. So afterload, normally when you saw the afterload refer to the load after the heart, meaning that the uh, meaning it's after found in the blood vessel artery. So that's why we call afterload. Preload we consider sometimes we call it as a venous, found in venous. So what I want to highlight is when you saw the preload not normally come into your mind is vein, and afterload automatically come into your mind is artery. So remember, afterload is for artery, uh, preload is for venous or vein. Okay. So that's how I mentioned that I I more prefer uh, this angiotensin northern and angiotensin converting enzyme inhibitor ACE and angiotensin blocker into another category, even though they have vasodilation side effect. I more prefer them stay according to the name rather than we consider them as a vasodilator. Okay, so uh, sometimes when you use a vasodilator, you need to consider to monitor the patient, especially the patient you you use together with digoxin. They might increase the risk of toxicity. Okay, increase the risk of toxicity. So according to this slide, vasodilator might divided into three types. So one is arterial vasodilator, second one is venous venal vasodilator, third one is Barron vasodilator. Barron's vasodilator refer to the drugs that are able to cause vasodilations for both artery and venous. They give you two example, ACI and ARB. These two category of drugs are considered as both vasodilator. So other arterial dilator, the famous member is hydralazine because they are quite specific. They add on artery only and cause arterial vasodilatations. By doing so, they will decrease the blood pressure and then reduce in afterload. Once your blood pressure decrease, your artery dilate, then your afterload will be going to reduce. You're going to decrease the burden to the heart. So meaning that your heart is not that difficult or no need to work so hard to pump out similar amount compared to the condition before taking these drugs. Okay, so study found that this hydrazine may involve in nitric oxide pathway. Okay, nitric oxide because this nitric oxide we're going to activate. Actually, nitric oxide only activate activate in the endothelium layer. When your blood vessel do not have an endothelium layer, uh, no matter how you activate nitric oxide, they will not going to produce nitric oxide because nitric oxide are only produced in your endothelium layer. So endothelium once produced from the endothelium, the nitric oxide will automatically penetrate because of molecular structures and size are quite small and then suitable for them to penetrate from venous into the uh, muscle layer. So from there, uh, the nitric oxide going to convert to cyclic GMP and then for further actions. Okay. So for nitric oxide pathway, definitely they need few enzymes. L-name is one of the important enzyme which is going to convert or produce nitric oxide and involve in the blood vessel. Second enzyme is soluble guanyl cyclase. Third enzyme is cyclic GMP, if I'm not mistaken. There are three enzymes involved with nitric oxide. If you miss either one, then the nitric oxide the pathway might not be completed, so the activity might not be obvious. So bear in mind. So until here, you only need to know nitric oxide is involved in hydrazine. That's all. The further information you can go and search and you can learn by you can learn. You can learn, you can understand properly, but not come up with exam. So until here, you need to remember hydrolyzing is normally related to nitric oxide. So the result is you're going to increase the cardiac output because why? You are decrease the burden. The burden refer to the blood pressure. So the pressure is become lower. So your heart is more easy to pump out blood from your heart. Okay, because the resistance is getting less compared to before taking the drugs, taking these drugs. So meaning that with the similar force of heart contraction, then you're able to pump more blood out from the heart after taking this drug. Okay, you get what I mean, isn't it? So you're able to pump more effectively. Yeah. So, of course, the IV drugs must have side effect. Happen in this drug also. They might cause nausea, hypotension. The nausea is sometimes is come from hypotension, headache, and also tachycardia. Then why tachycardia? Because your heart is going to overcome the condition. That's why it becomes tachycardia. Because the pressure suddenly drop, then your autonomic system try to adjust and then activate your sympathetic nervous reactions, so may cause a tachycardia. Okay, this one sometimes may also happen. No? So for vasodilator, there are two commonly used drug is nitroglycerin and isosobat dinitrate. Okay, these two drugs normally will cause vasodilation in venous and vena cava. Vena cava is a vein that bring and some and the blood from your whole body into your heart. We call vena cava. The blood vessel that connect your heart to others blood vessel. The vein connect your heart to others. Then that the vein we consider a vena cava. So once the vein is dilated, especially largest vein is dilated. So the period will going to decrease, meaning that your venous return will going to decrease. So amount will return to your heart will be decreased. So why? This is sometimes you might think this is opposite the actual outcome that you want, isn't it? Actually, when you decrease the volume of blood into your heart, then this action may going to reduce your heart burden. So your heart will no need to receive so many amount of blood in one time, and then the heart able to pump effectively. Okay, that's why uh, these are helping the patients. So the adverse effect is may cause headache, dizziness, vasomotor flushing, uh, and hypotension as well, and reflex tachycardia, which is more or less similar as arterial dilator. The third drugs we are going to study is ACEI and ARB. This one no need to know. I think all of you we do discuss this one in detail last week, isn't it? So this slide try to show you the difference between ACI, ACE. So how's these two drugs going to react? This one also has been discussed. So so today we are not going to repeat again. So another thing is I want to recall you could recall back, remind you. So ARB do not affect bradykinin, which is we do discuss last week, isn't it? ACI do increase. Actually, we can now say increase. ACI do decrease the inactivations of bradykinin, meaning that bradykinin will stay longer time in your body. So they are the two obvious difference between ACI and ARB. Okay. Another thing is ACI may cause dry cough. Uh, may cause dry cough. Okay, dry cough here. So these are the member of vasodilator normally used in chronic heart failure patients. Okay. So sometimes chronic heart failure patient will also using uh, beta blocker. Okay, so beta blocker normally will block on the actions of norepinephrine or epinephrine. These two, these two, these two. So for beta blocker, since your heart is consists beta blocker receptor, especially beta one. So once you block the beta one, you are going to decrease your heart rate and the force of contractions. So these actions, as I say, seem to be opposite to the effect requirement is in the cardiac output. Actually, you block the beta 1 receptor. The purpose of you block beta 1 receptor, you is try to reduce the stress. Okay, allow the heart to full and functions more effectively because you are slowing the rate. Do still remember that day I do mention if your heart is pumping very fast, even though numbers of pumping is increased because very fast, but it's not effective. Why? Because the heart is not fully pumped out. Okay, fully pump out the content, meaning that the blood from heart. So in order to pump out 1 liter, you need to pump more than 3 times. But in normal condition, if your heart is able to pump effectively, you take 1 time of pumping, you're able to pump out similar amount as you take more than 1 time. So so if you use beta blocker, you are able to allow the heart to uh, pump out effectively. That's why beta blocker is quite effective. Secondly, beta blocker will reduce the heart rate. Will reduce the heart rate. By doing so, the heart will not pump so fast. Okay. So this topic try to learn by heart is quite important because beta one receptor, beta blocker especially learn by heart. I do remind many times this beta blocker is quite important. Okay. Beta one not only add on beta one blocker not only add on your heart but also add on the cell in your kidney, especially the cell we call it as a juxtaglomerular cell, which is release renin. So if let's say you're able to block the beta receptor, which is found in juxtaglomerular receptor, meaning that you're able to reduce the productions of renin. Okay, production of renin. So you are going to inactivate the RAA, renin angiotensin, aldosterone, RAA mechanism. Still remember, renin is a precursor for this RAA mechanism. So the example of beta blocker that used for chronic heart failure is metoprolol, bisoprolol, carvedilol. Okay, remember carvedilol. Other polo have similar mechanism. Only carvedilol have slightly different. So you remember carvedilol because carvedilol not only add on beta one, might also add on alpha one as well. Okay. So remember, carvedilol have it's not we can consider it not a specific beta one receptor blocker. These drugs are able to add on alpha one as well. Okay. So cardiac glycoside is isolated from a plant we call Digitalis lanata. Okay, Digitalis lanata. Okay, this drug able to increase the cardiac contractility, means that able to help the uh, heart to contract. Okay, so the pharmacology effect is they were going to force the myocardium to contract. That's why we say this drug might increase the cardiac contractility. So this one we consider as positive ionotropic effect. Okay. So another beauty of this advantage of this drug is once, even though it can cause contractions, but also the contraction will not causing an increase in oxygen consumption. Why? Because this drug is not going to increase the numbers of contractions, only increase the force of contractions. So, so by doing so, so you do not have extra, you do not to need extra oxygen to cause the pumping compared to before using the drugs. So that's why we say that without causing an increase in oxygen consumption. Okay, by doing so, your performance of heart will be improved. The the blood that enter your systematic circulation will become normal. I refer to the amount of blood. So once you restore the normal blood circulation, your heart function will going to increase automatically because your kidney will going to have sufficient of blood to sustain the cell there. So that's why kidney function will be increased directly because you are using this cardioglycoside. Okay. So by doing so, your kidney able to excrete extra fluid and ions that are associated with edema. Okay, quite clear. So another thing is digoxin may stimulate your vagus nerve, especially your parasympathetic effect. So once you stimulate parasympathetic effect, you will slow the activity of SA and AV nodes. Slow the activity. So you will decrease the AV conduction. Especially. So these are suitable for heart block condition. So meaning that digoxin not only used for heart failure, sometimes may also use for heart block conditions. Okay. This figure try to tell you there's few conditions normally happen in heart. So one is arterial fibrillations. So look at the ECG here. You cannot see the P wave here because of fibrillations. Heart, the atrium pumping too fast, so the P wave is disappeared. And then ventricular fibrillation even worse. Your ventricle is pumping irregularly. So you looking at this ECG, you might not see the pattern. Okay. So what the digoxin may do is digoxin may help in type 1 and type 2 degree of heart block. Okay. Okay. May help, may restore the condition become normal. So when you want to use this drug, first thing you need to remember you have to control the conditions of patient variable, especially the pulse. You always need to check the pulse frequently. So the pulse should be perform the heartbeat 60 to 100 beat per sec per minute. Okay. Once your beat is out of this range, then you need to seek the attentions of physicians to adjust the dose. Okay. So the mechanism of action is you need to remember is digoxin inhibit the enzyme of natrium kalium adenosine triphosphate. Okay, natrium kalium ATPase, which is located here. You're going to increase here the enzyme here. So by doing so, uh, you will lead to accumulations of sodium inside the heart muscle. Sodium will inside heart muscle because this channel we're going to pump sodium from inside to outside. So once you inhibit this channel, what will happen, or this pump, what will happen? Nutrients are not able to pump out, so they will accumulate inside. Okay, first thing you need to manage nutrient will accumulate inside. So once the nutrient accumulate inside, nutrient will will add on this natrium calcium channel exchanger. This natrium will inhibit the natrium calcium channel exchanges. So once you inhibit this natrium channel calcium exchanges, what will happen? Your calcium will stay inside your intracellular. So by doing so, your heart can able to pump more effectively because of the calcium. Okay. So digoxin may use either is IV or PO, depend on the condition. Just now I do mention, isn't it? Depend on the conditions. Uh, some of the not some, digoxin only one. Digoxin, the normal half-life is 1.5 to 2 days. The half-life is quite long, especially the eldest patient. Elder patient, the half-life is longer compared to youngest patients. Okay. So another thing you need to remember is diagnostic affected by changes in the cellular electrolyte, particularly potassium and calcium. Okay, if you use digoxin with directly, which is may cause hypokalemia, then this hypokalemia condition may sensitize the heart to be toxic effect of digoxin. Means that you use, let's say you didn't control the dosage well, you use directly, you use digoxin. Directly, as we know, not uh, normal directly like thiazide, looks directly may cause hypokalemia, isn't it? So this hypokalemia may cause sensitize or sensitize, or means that increase the toxic effect of digoxin if you use digoxin together. Okay, bear in mind this one. Okay, may also increase the incidence of anemia. Okay, incidence of anemia if you use directly together, or not only directly lah, those drugs that can cause hypokalemia. Okay, quite clear. If let's say you use the direct directly, which is may cause hyperkalemia, then you will antagonize the digoxin effect. Means that you're going to decrease you are not introduce a toxic, but you decrease the activity of digoxin. Okay, sometimes hypercalcemia uh, may enhance or digoxin may lead to anemia as well. So when you use digoxin, you need to make sure that the patient's the serum electrolytes is in balanced conditions. Not in balanced condition, is in balanced conditions. So when you use this drug, or especially for chronic heart failure patients, you should control the diet. Food juice, especially banana or others vegetable, because nowadays people like to blend the vegetable together with food and then drink such juice, isn't it? So you might introduce high potassium, hyperkalemia to the patients. So bear in mind. So when you take these drugs, normally you try to avoid taking those food that have high content of potassium. So ever expect is cardiac arrhythmia. Okay, you might have atopic bit. It means that as extra a bit of found in your ECG. Okay, so once you have overdose toxicity, what you need to do is just inject immuno FAB. Means that it's an antibody or monoclonal antibody which is able to bind the digoxin so that to reduce the bioactivity of your digoxin. Okay. So the drug interactions, antacid, laxatin, colimpatin, cholestyramine, those are able to decrease the absorption of digoxin in your GI tracts. So arrhythmia drugs, quinine, we are going to study this one later. And anti-arrhythmia drugs, we're going to increase your digoxin plasma level. So when you want to use, yes,
没有，那个
okay,
有声音，但是我是大会流的。必须得可能当。你太不了。
okay, okay. So we continue. So other drugs that increase the myocardial contraction is such as dopamine might also sometimes may introduce for chronic heart failure. Arinolone and milrinone might also, which is might also introduce to uh, the patient. But okay, so so I finished today lectures. Tomorrow lecture can we bring to after 8 because tomorrow I need to attend the convocations. I don't know when the convocation going to finish. We start at 10:30. Definitely cannot finish before 2. So we need to postpone the class to night class. Okay? We postpone the class to night class. Okay, isn't it? For you. Tomorrow, because our class is 2 o'clock, isn't it? So I don't think so I able to the convo is finished before 2. So this afternoon and then the practical class we're going to operate as usual. Okay? Tak ada masalah, so we dismiss today class. Okay? See
Okay,
you
doctor.
afternoon. Bye bye.